Okay, so can you hear me, Joseph?
Yes, I can hear you.
Okay, so today I'm going to present a human DX case to Joseph, and for those of you who have not yet heard of the human DX app, so it's an application which you can get whether you're using Android operating system. I believe in the even in the App Store it's present. So they present cases in terms of value quotes, just like we do in these sessions, and there are so many cases, so you can have that and use that for your day-to-day learning, solving cases, and then they have some teaching points at the end. So I picked a random case, although this is an old one that I solved in the past, and I'm going to present it to Joseph. Yeah, so Joseph, today we have a 46 years old male who presented with jaundice. Joseph, you are muted. Oh, okay.
Yeah, yeah. Yeah, thank you very much. Jaundice is quite a common complaint, and we've had a couple of cases here in patients with jaundice. So for me, it's easier to approach jaundice when I translate it pathophysiologically. Jaundice, the yellowing of the eyes and other parts of the body, is the yellow thing is the bilirubin, means the bilirubin is high. So you go down and find out what is the causes that can cause a rise in bilirubin, and you arrive at a differential diagnosis of a jaundice. But mainly, it's two things: there is a problem of the RBC or a problem of the liver. Period. So as we'll be hearing the story down there, it will be up to us to pinpoint is the problem of the RBC or the problem of the liver. The problem with RBC is just hemolysis, and so there will be symptoms there. But on the part of the problem, the liver, a lot of things is there are there like obstruction and stuff like that. So let me stop there and hear the HPI.
Yeah, good start. Uh, So this patient presented with a progressive generalized yellowing of the skin and eyes, which started 2 days prior to presentation, along with darkening of urine. Also, the patient presented with progressively worsening generalized headache, which started at the beginning of the previous week. He had one episode of emesis prior to arrival to the ED, but he did not report any diarrhea, abdominal pain, fevers, or chills. So that's the first aliquot.
Yeah, so pretty important information there as far as jaundice is uh, is uh, is considered, and so it's an acute jaundice. It's just 2 days, and being told here the urine of this patient is also dark. So you think of the things that can darken your urine, and it's not a lot. Bilirubin itself is one. The RBCs, they're also another thing, and HB is also another thing that can darken your urine. Lastly, if you talk about HB, also talk about the myoglobin, its friend. So like four things. So one of these things will be present in the urine of this guy. So because we're talking about bilirubin here, you have to assume this is also was seeing the urine is bilirubin. So what I'll be doing as David is presenting the case here, I want to know whether we're dealing with because if you say hyperbilirubinemia, it's just two types. It says a direct hyperbilirubinemia or an indirect hyperbilirubinemia, conjugated and unconjugated bilirubin. So the direct hyperbilirubinemia, or let me start with the indirect hyperbilirubinemia, the one which is not has not passed through the river, so hasn't been conjugated yet. And we have a couple of courses here. Many of them I was talking about the hemolysis, but there are other. problems of the liver, uh, which impairs the conjugation system. You think of genetic diseases like Krieger-Naja or another two that I think are running out of my mind right now. But so we know that when we are told about what's the bilirubin of this guy looks like, is it half of it conjugated or half of it unconjugated? But on the other hand, if you have um, the, 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 the direct hyperbilirubinemia, one which was already being conjugated, now you think, why is it spilling over in the blood? It's because either there is an obstruction somewhere. Yeah, so that's it. But also the patient has a symptom. We're told that the patient had headache, which started the week prior. So headache in this case will be a secondary headache, very non-specific, whatever secondary thing can cause headache from infectious process and others. Also, emesis, again, pretty non-specific thing. But what we take from this is that this disease is not just 2 years, a progressive disease of 1 week. Patient starts with non-specific symptoms, and then at the end we are seeing something which is specific and which can help us localize the disease, and which is jaundice. So I think it would be unwise to start and pinpointing what's the differential diagnosis at this stage before hearing other information. David.
So, Joseph, can you repeat the four things that cause darkening of the urine? I think that was very worth noting. Can you repeat them?
Yeah, so we said hemoglobin and its friend myoglobin. And I said again bilirubin itself. And what did I say? The first thing I even forgot what did I say. Uh, I said hemoglobin and myoglobin, bilirubin. Oh, forgot the fourth thing I said. Did I say three or four?
Yeah, was it the RBCs themselves, if I remember
Yes.
correctly?
Yeah, RBC themselves. Yeah,
Oh,
that's true.
yeah. So we proceed to the past medical history. So this patient had a history of Lyme disease 2 months prior to presentation. Presented with a bullseye rash and was treated with doxycycline. He is not on any medications, and past the surgical history, he had a history of splenectomy 10 years prior to presentation. And that was after motor vehicle, that was after trauma. And so social history has a remote history of alcohol use, but no tobacco or drug use. So I'll just combine that with review of systems, which was the third early quote. The review of systems, apart from what has been reported in the HPI, otherwise there is nothing remarkable. So anything that's striking to you, Joseph, in the past medical history?
Yeah, um, yeah, pretty important things. One is uh, he had Lyme, and Lyme was treated. So I think Dox is the light medication to treat Lyme, and I don't think we have to talk about Lyme now. Now we have to think what we are seeing is it the consequence of that Lyme. I'm talking about maybe the doxy, relationship with doxy and the jaundice. Is it possible? Probably. Any medication can do anything. So if you're talking about jaundice, I said you're touching the liver there. And if you say a medication like doxy, you say, okay, maybe doxy can cause some liver injury. Is it possible? I'm not sure. It's not the capital we are used to. But if you're not sure of anything causing liver injury, you go online, and there is a website. I think it's called the liver tox. Liver tox. There is all medications are listed there, and the propensity of them causing a liver injury, like the percentage, how frequent. and so you just go and plug in a Doxin C. So I'll keep the Doxy on my back of my pocket to think maybe it's related, but maybe not. It's just he had a Lyme given Doxin, it's not related. And splenectomy is important, 10 years. So the spleen part of immune system. So you can say in some ways this patient is immunocompromised. He doesn't have a spleen, and is being in a risk of several infections that we usually talk, say, the encapsulated organisms, things like uh, H flu, the Haemophilus influenza, the pneumococcal, and others. So maybe they're related, maybe. So we know that he is immunocompromised, doesn't have a spleen. We also keep this information important that at the end of the day, if you're dealing with an infectious process that can explain jaundice, we will remember his spleen is not there to protect him from some infections. Patients not drinking alcohol very good because we're talking about the liver here, and alcohol is one among the toxins that implicate the liver. So yeah, splenectomy is important, and the medication that patient used 2 months ago, dox is also important in this case as far as his liver is concerned. So I think we should proceed.
Interesting discussion. So we go to physical exam. On vital signs, his temperature was 39.3 degrees Celsius. The pulse rate was 95, respiratory rate 20, blood pressure 104 by 45, saturating 94% on room air. On general exam, not in acute distress. The head, eyes, ears, nose, and throat. He had a icteric conjunctiva. The pupils were equally reactive to light. Lung examination, clear to auscultation in all lung fields. Cardiovascular examination, regular rate and rhythm, no peripheral edema. The abdomen was soft, non-tender, non-distended, no organomegaly. Skin exam, there was no rash or lesions. And neuro exam, no focal deficits, and the patient was alert oriented times 3. That's physical examination, Joseph.
Oh, I'm muted. Yeah, thank you. So what we are seeing from this physical exam, that patient is not it's not so much, it's not like a very sick patient. And what to pick from here, patient is February 39.3, and then he has jaundice, and was the blood pressure 104/45?
Yes, 104/45.
Okay, so also there is hypertension in some ways. So seeing this patient like in real life, you vitals are vital. So you start with the vitals. Blood pressure is low. You can have a low blood pressure without being in shock, and you can have a shock without having a normal blood pressure. So you examine this patient. Uh, you expect maybe you can see cold, clammy extremities, but not necessarily. Think of it when they have maybe distributive shock from sepsis, for example, and uh, the extremities aren't necessary to be cold and calm because blood is flowing there. It's that the tone of the blood vessels is down. So I can say this patient, we can say being with fever and that hypotension, you start them on fluids immediately before figuring out what is troubling them. General exam, we're being told uh, he has jaundice, which we know, but also he has a fever, 39. So the problem now changes. It's not just jaundice, it's jaundice plus fever, which means when we say fever, we mean it's an infectious process unless we prove otherwise. Most of the time around here, it's hard to prove otherwise. But we should first consider an infectious process without delving into other categories. So, if it's an infectious process, it can be on both sides. I said jaundice is either the RBC or the liver. So both they both can have an infectious process affecting them. So around here, think of a malaria. So malaria can cause hemolysis. You can have indirect hyperbilirubinemia, and you have a fever. This patient is not from Tanzania or from Africa, probably. So you have to consider globally. And if you say malaria in this area, go to the above the equator, US and wherever, they talk about babesia, present the same. They say it's a American malaria, the babesia. So those infections can be there, but also there are viral infections that can cause hemolysis, and then you can present with the with the fever and jaundice. On the other hand, again, on the part of the liver now, there are causes that there are infections that can cause also jaundice, and we're talking about viral hepatitis, for example, hepatitis A, hepatitis B. They can cause a fever, and also they can also cause a jaundice. But it's not just the liver parenchyma, also an infection of the biliary tree, which is less likely in a patient whose exam is completely normal. There is no tenderness on the right upper quadrant, for example. It's likely to be something that implicates infection of the biliary tree. So yeah, but we have to go with all of those. Uh, so yeah, I think I'm there now. I consider infections that can affect either the liver plus or minus the BA3, and on the other hand, infections that implicates the RBCs. And yeah, so the like the labs that you send would be ruling out those infections first of all, before considering other things. So David, I think should proceed.
So maybe you can summarize from beginning to the point where we end your thoughts so far for those who have joined.
Yeah, so this is the case from AfroDX that David is presenting of a 46-year-old male who presented with the jaundice for 2 days. Associated symptoms include a dark urine, a headache which started the week before, uh, um, one episode of vomiting, but in history there is no fever. Past medical history: patient had Lyme 2 months ago, was given doxy. Also, there is also a history of splenectomy from trauma 10 years ago. Patients used alcohol in the past, not now. Physical exam, not much. On the patient is jaundiced, otherwise the general exam is normal. Vitals, they have a fever of 39.3, a tachypneic at 20, and the hypotensive at 104/45.
Okay, thank you for the summary. So we go to the labs. So the labs CBC WBC count is 11.5, and the normal range here is 4.5 up to 11. Hemoglobin is 11.1. The lower limit there is 12.6. The lower limit of the normal range. MCV 90. Platelets 123,000. The lower limit here is 153. And the complete metabolic panel: sodium 131, potassium 4.9, chloride 95, bicarb 26, BUN 38, creatinine 2.8, that is milligram per deciliter. The upper limit is 1.25. Glucose is 108 milligram per deciliter. The upper limit is 99. AST 79. The upper limit here is 59. That was AST. ALT 60. The normal range is from 0 to 49. T-Billy 11.2 milligrams per deciliter. The normal range is 0.3 to 1.2. And then direct bilirubin is 7. The normal range is less than 0.4. Alkaline phosphatase 155. The normal range is 38 to 126. And then urinalysis: negative for bilirubin, normal urobilinogen, trace ketones, 2 plus blood, and 11 to 25 RBCs per high power field, negative leukocytesterase plus nitrites. So those are the labs. If there is anything that you didn't catch, feel free to tell me to repeat it.
Yeah, does did you say the protein in the urine?
No protein in urine was reported. I mean, this UA did not report protein at all. So it was negative bili, negative urobilinogen, trace ketones, 2
Okay.
plus blood, and then some RBCs 11 to 25,
Okay.
negative leukocytesterase plus nitrites. Protein was
Okay.
not reported.
Okay. Yeah. Thank you. Yeah. So uh, those are remarkable labs. So let's dissect them and see if we can make a progress around here. So let's start with the CBC. Slightly elevated white count, inflammation, which is there. Patient is fever. We expect it. There is anemia of 11.1 based on that lower limit, I believe, and there is also a mild thrombocytopenia of 123. So one, as far as the CBC is concerned, before I proceed, is that a thrombocytopenia of a mild thrombocytopenia plus an anemia makes you think that in a patient whom you suspect there is infection, it's highly likely you suspect that an infection is coming from outside. Things like a malaria. So it's a picture that you see every day of a malaria patient with slightly reduced HB, they have a low HB, and then they have a low platelet. So on the other part of the world, they think of Babesia presenting in the same way. But is it true that we should be worried about that thing? Because when you talk about that, you say, okay, there is hemolysis. But you look at the lab, especially the total bilirubin of 11.2. There is one caveat that I think I've learned. Hemolysis hardly will take bilirubin above 6. Once bilirubin is above 6, it's an obstructive thing, less likely to be from hemolysis. So that process, maybe there is an hemolysis, maybe if it's coexistent with something which is obstructing. And what else that shows is the direct bilirubin is more than half of the total bilirubin, which means there is this is a thing called a a conjugated hyperbilirubinemia or direct hyperbilirubinemia, and this will be the, the 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 center of gravity of the case. Everything that we will be discussing, everything that we'll be saying at the final diagnosis should center this, that there is something obstructing the biliary flow in this patient. So before delving into what is obstructing, we look at other labs. So hyponatremia of 131 is nothing. Patient is vomiting. So it's just a fluid imbalance there, increasing the ADH, and the ADH, you have a dilution, then you show like a mild hyponatremia. You give this patient fluid and the sodium is being corrected. Another important thing is a creatinine of 2.8. So we don't know the baseline. If you don't know the baseline, you have to assume is Aki. Because if you assume it's CKD, you won't progress. You just end there. You don't know a lot of things. So you assume this is Aki. In a patient who has vomited, the most common cause of Aki in hospital, by the way, is Aki. The patient with they have they are fluid down. Maybe they are vomiting. They are sick. They are not being eating. And how would you know that? So you give these patients fluid 1 to 2 liters, and then you expect when you take again the creatinine, it has normalized after replenishing their fluid. But if it does not, it means either it's not a pre-noaki, it was an intra-renal post-noaki, or it was a pre-noaki which has progressed into an intra-noaki. But one thing is telling you, maybe this is less likely to be a pre-noaki because of the urinalysis. So pre-noaki, you send the urine, it's a bland urinalysis. It's normal, you don't see anything. But in this patient, you're seeing there is blood. One also learning point, the blood in the urine analysis that you put the urine strip, you insert in a urine analyzer, it says blood. It cannot tell whether it's RBC, whether it's HB, or whether it's myoglobin. It just say positive. So that's why they also do microscopy, and David has told us, both of them told us the UA showed 2 plus RBC, and when they looked on the microscopy, they also saw RBC. So we are dealing with not the HB in blood, not the bilirubin, not the myoglobin in blood. We are dealing with the blood in urine, hematuria, microscopic hematuria. So we'll be having other problems that are arising. We have an Aki that we think is an intrarenal Aki with microscopic hematuria in a patient who has direct hyperbilirubinemia. So we'll start with the direct hyperbilirubinemia. I said this has to be a problem of biliary obstruction somewhere, and the obstruction can happen in the liver or outside of the liver. So in the liver, we are talking about things like think of cirrhosis, for example. But you know, okay, cirrhosis doesn't present like this. There is nothing else that David has told us that points to the way of the stigmatas of chronic liver disease in this patient. So less likely this can't be a cirrhosis. But also drugs, yes, drugs, the liver injury. Liver injury is very possible. If you have read liver injury and they describe the patterns of injury, they will tell you whether that drug affects more the hepatocyte or the cholestatic pattern. So, which means the drugs affect inside the liver, not outside. So it's an intrahepatic cause of hyperbilirubinemia also. So yes, this patient was given doxy. We put it there that probably this drug-induced liver injury. DILI, causing what we're seeing here. But of most important, without forgetting viral hepatitis. Viral hepatitis also, they implicate the hepatocytes, so they are, it's a cause of of jaundice and fever from the intrahepatic region. So we also put it aside. We will send hepatitis B, we will send hepatitis C in this patient, we will send hepatitis A, trying to figure out what is happening. The extrahepatic is interesting, and also these, when think about how the bile flows, it goes from inside the liver and it collects itself. There are two tubules there which connect to form a common bile duct. So you can think of anything that will obstruct the common bile duct, either from inside, from the walls, or from outside. Most common, you have a stone, a CBD stone, a common bile duct stone which obstruct there. This patient will present with pain, up the right upper quadrant pain. Fever will come later as a complication. Doesn't look like this picture. Some other rare things can also sit there. A sludge, which is like not a real stone, but a soft stone, like a mud sitting in there. Also parasites that less likely. You think of things which can come from outside. You can have a lot of lymph nodes. Some of them can be sitting just next to the common bile duct. They compress and they cause jaundice, and also causes from the walls. You can have autoimmunity. Autoimmune diseases which affect the walls of the common bile duct and cause disease, also even malignancy. But I'm getting a flavor that this will not be the case of extrahepatic obstruction of the biliary, because most of these cases, as far as I remember well, will present with pain. So I think we have to delve into the intrahepatic causes of fever, intrahepatic causes of fever, jaundice, plus uh, intravenous. And I will prioritize infections. That's why I will send infectious workup of the hepatitis type. But again, I won't take lightly the I won't take lightly the medication that I've been told. Although not sure that it causes the doxy. Or I won't talk away. If I have nothing else to explain this picture, I'll have to implicate the doxy at the end. Um, Other issues, the ALP is also elevated. So it is not elevated alone, which is easy. It's also elevated with the AST and the ALT, and it tells you there is a cause, there is a liver injury in this case, which is also likely to be infiltrative when the ALP goes high. Although it's not that much high, but I use the ALP for that matter. That there is a cause that is injuring the hepatocyte, but if the ALP is high, I also think it can be an infiltrative cause. Um, so to make progress, I think we have to first of all, if we will be told how the creating went, um, so that I consider my causes of intralineal archy and pair with what I've discussed. Also, to send those labs that I've said, if I get those labs, and see where I do what I do. Yeah, David, back to you.
Interesting discussion. I hope people are taking notes. So we proceed. So the next aliquot is imaging, and this will be the last aliquot before revealing the final diagnosis. So imaging, ultrasound abdomen was done, and what it reported was cholelithiasis with gallbladder wall thickening. Although there is a comment that these are non-specific findings, but can be seen in cholecystitis. And I think hepatomegaly also was reported. And MRCP reported cholelithiasis and pericholecystic fluid with no associated gallbladder distension or gallbladder wall thickening. So that was it. And if you have anything before we reveal the final diagnosis and read the teaching points. Joseph, if you are speaking, you are muted. Hello, Joseph. Okay, I saw Joseph disappearing but came back. Joseph, are you there?
Yeah, hello. I had trouble with my internet, but I think I'm back.
Yeah, so did you hear the last early quote that I read?
No, can you repeat it?
Okay, so this is the last one. So it was on imaging.
Okay.
Imaging was done an ultrasound abdomen
Hmm.
reported cholelithiasis with gallbladder wall thickening, but there was a comment that these are non-specific findings but can be seen in cholecystitis, hepatomegaly. And MRCP also revealed cholelithiasis and pericholecystic fluid with no associated gallbladder distension or gallbladder wall thickening. So that's the last early quote. And after
Can
that,
you repeat the ultrasound?
yeah, the ultrasound reported cholelithiasis with gallbladder wall thickening, but these are reported as non-specific findings.
And then the another image.
MRCP, cholelithiasis and pericholecystic fluid with no associated gallbladder distension or gallbladder wall thickening.
Okay. Okay. Yeah, thank you. So let me put it together. So let's look the case through the imaging. Cholelithiasis is just the presence of the stone in the gallbladder, period. The ultrasound says there is a wall thickening. We use wall thickening to say this is not just cholelithiasis, it's cholecystitis, an inflammation of the gallbladder wall. But you look at the case, there is no pain. A right upper quadrant pain, positive Murphy, these are the signs and symptoms of a cholecystitis. So I think we'll make a progress if we just exclude probably this finding. Another thing is that MRCP was done. MRCP to have a rise in bilirubin. Yeah, let me repeat that. That's very important. To have a rise in bilirubin, you don't just have to have a cholecystitis or a cholelithiasis. A stone present in the gallbladder, either is causing inflammation or not, shouldn't cause hyperbilirubinemia unless it causes complications. One is that maybe it's too long, there is edema, and then the infection is ascending in the biliary tree, you have jaundice later. Not this how this case looks like. Another is that as I said, what causes jaundice in a patient like this, there is no pain? Maybe something which is sitting in the CBD. That's why they had an MRCP, which showed no stone in the common biliary duct. So I don't know, but for me now, the stones will be out unless I think is there something else that should be done to see this. Um, I doubt so because MRCP is the one that we use like to rule out a CBD stuff. Yes, I think that's okay. So I'll say it's not a stone. Also, it doesn't look like a stone. Now, what else would it be? We haven't been told about. We haven't been told about the infections that I said that we need hepatitis B, we need hepatitis A to see if we are also dealing with viral hepatitis in this case. So I'm going back and re-summarizing the problem of this case is that this is more likely to be an intrahepatic cause, an intrahepatic cause of jaundice, presenting with fever and Aki, which is more likely because they they haven't been telling us that there was a normalization of the creatinine, for example, after giving this patient fluid. I assume it persisted. So intralineal Aki, intrahepatic infiltrative cause, intrahepatic infiltrative infection. Should I say this is hepatitis? Highly likely, but taking care of a few patients of hepatitis B acute and some hepatitis that I thought is A, and we didn't arrive there because we didn't have the test. I don't remember seeing intralineal in those patients. So what else if I'm thinking of an infectious process that can infiltrate the intrahepatic stuff and then cause Aki? If someone can get that, I think that would be the diagnosis. And so for me, another thing that I should think the infection, yeah, let me think, leptospirosis. So I also think of leptospirosis. Although this patient is not a typical patient of a risk factor to have leptospira, that they are working in places that they'll be coming into contact with rats and stuff like that. But I also have, if I send hepatitis B, A, the negative, also send leptospirosis. Leptospirosis can explain the ARCI, the intralineal ARCI, but leptospirosis can cause jaundice, can cause infiltration inside the hepatic parenchymas that the hepatic biliary system that and cause intrahepatic obstruction of the bile, leading to this sort of disease. Do I have any other thing? Let me see. So yeah, so in terms of infection, that's what I'll be doing. Yeah, I said doxy. So doxy again, it will be hard for doxy to explain the intrahepatic, the intrarenal archy again. To be very hard. Maybe it causes DILI, drug-induced liver injury, and DD can present with a fever. Don't be surprised. I've seen that DD is a fever, but it will be hard for that to explain it. But if I do all the stuff, this will be a diagnosis of exclusion. I do all the stuff, and then there is nothing that's showing up. I say maybe we're dealing with a doxy-induced DD. Other than that, I don't think if I'm remaining with anything. Yeah, so David, that's where I'll be. First, I'll send hepatitis BA, nothing. I'll send leptospira tests, all of them negative. Maybe I'll consider the doxy. But another question will be coming: what if this is a stone and you just not the MRCP and the USS are not seeing it, but the doesn't present like this. I expect pain. Personally, I expect pain. Yeah, David, I'll be there. Leptospira, hepatitis, uh, doxy. If it's an infectious process, Leptospira is up there. Uh, Tell us, teach us what happened.
Thank you very much, Joseph. Meticulously dissected, and well, I am personally very inspired because lots of teaching points and then very broad thinking. So that's knowledge that you get from exposure from solving or listening or reading many cases. Because just from seeing Lyme, Joseph could tell that this was a patient who is most likely not in our setting, because yes, I've not heard if we have any Lyme cases in our setting, but at least we are sure our country is not endemic to Lyme. So this was likely a case from somewhere in the United States, and of course the diagnosis was a surprise. But what's interesting is that it was one of the quickest of the very first differentials that Joseph mentioned. So the final diagnosis was babesiosis, that is infection with babesia. And so for I read the teaching points, and then Joseph will give us his reflections. So on case resolution, following the imaging findings, the patient was started on zosine, so that is piperacillin tazobactam, for empiric coverage of presumed ascending cholangitis. But the patient decompensated, developed both uh, ARDS and acute renal failure, which required ICU admission, as well as CRRT. So that's a sort of renal replacement therapy, which is continuous. So it's dialysis basically. And as he was developing worsening renal injury resulting in oliguria, hyperkalemia, acidosis, and volume overload. And shortly thereafter, a serum Babesia IgM and PCR both returned positive, and a diagnosis of Babesia microti infection was made. So, given a recent history of Lyme and lack of travel to a malaria endemic region, Babesia was most likely, and he was started on treatment. And the patient was started on atovaquone, 750 milligrams BD and azithromycin, with a slow improvement in clinical status over the following week. So both the ARDS and ACI resolved with continued treatment of his babesiosis, and he was discharged from dialysis with outpatient follow-up. This patient had a recent history of Lyme disease, which is transmitted by the Ixodes tick, and it's the same tick that transmits Babesia. So, in retrospect, this historical clue was helpful in making the eventual diagnosis. And this case took place in Maryland, which is an uncommon location for Babesia infection, and this is what contributed to the delay in diagnosis. So in terms of epidemiology, Babesia microti is transmitted via the Ixodes tick, and the white-footed mouse, among other rodents, serve as the primary reservoir, and humans are incidental and terminal hosts. In addition to tick bites, Babesia can also be transmitted via blood transfusion or transplacental transmission, which is rare. Infection is most common, and this is North America, in the US, in Massachusetts, Connecticut, Rhode Island, New York, New Jersey, Minnesota, and Wisconsin. And this pathogen has been spreading, and incidence of infection are increasing in other parts, even in the northeast of the US, including Maine as well as Maryland. And most cases occur in summer and in regions where humans are in close proximity to ticks and deer. So in terms of pathophysiology, Babesia microti is a protozoan parasite that infects erythrocytes, resulting in a hemolytic anemia similar to malaria. And the primary vector is Ixodes scapularis tick, the same vector that transmits Borrelia burgdorferi, which causes Lyme, as well as Anaplasma uh, phagocytophilum, which causes anaplasmosis. And clinical presentation, clinical manifestations of Babesia range from asymptomatic to mild to fulminant, resulting in death. Incubation period is 1 to 4 weeks following tick bite, or up to 6 months following transfusion of blood products. Clinical syndrome may include the following symptoms, from most common to least common. So there is fever, fatigue, chills, sweats, anorexia, headache, myalgia, nausea, cough, as well as arthralgia. So the diagnosis is made based on hemolysis on lab work in conjunction with appropriate epidemiologic exposure that is suggestive, and confirmatory diagnosis is via GIMSA or right stained thin blood smears or PCR. And PCR is more sensitive, especially in the setting of low-grade parasitemia. If thin blood smears are used, the multiple should be obtained to increase sensitivity. Treatment depends on severity of disease. Mild to moderate disease in ambulatory patients, it's a step-down regimen starting with atovaquone 750, 12 hourly plus azithromycin 500 milligrams on day 1, followed by 250, 24 hourly for 7 to 10 days. And for severe disease among hospitalized patients, it's atovaquone 750 milligrams BD, that is per oral, plus azithromycin 500 milligrams IV, 24 hourly until symptoms resolved, and then followed by step down therapy, as I mentioned, for ambulatory patients. 500 to 1,000 milligrams azithromycin should be considered for immunocompromised patients, and total duration of treatment is typically 7 to 10 days. So a general teaching point, it's important to keep a broad differential when considering jaundice. This patient was initially thought to have cholestasis of hepatic origin, given ultrasound findings in conjunction with a predominant increase in direct bilirubin. It is likely that his critical illness was causing cholestasis, resulting in direct hyperbilirubinemia. In this case, he had both an indirect and direct hyperbilirubinemia from both hemolysis as well as cholestasis. So it's important to consider that two etiologies can occur in the same patient. And a clinical PEL is that asplenia, remember this patient had splenectomy 10 years prior, is a major risk factor for developing severe babesiosis, even in a low-grade parasitemia, as the spleen normally clears infected erythrocytes, and severe infection may result in ARDS, DIC, renal failure, or relapsing cause despite appropriate therapy. And as you can remember from the case, this patient complicated with ACI and ARDS. So that's what we have, Joseph. That's what we had for today, Joseph. Any reflections from you?
Yeah, there is zero way that I could have got this right. And yeah, thank you very much. That's a very good teaching point. So I assumed, for me now, my my downfall, I assumed, for example, once it's direct hyperbilirubinemia, it has to be an obstructive cause, just that, and no hemolysis, stuff like that. But as you told us there, one thing can result into another. Yeah, I agree with that. Cholestasis of cholestasis of sepsis, for example. Patient is too sick, they can have cholestasis, and then they have hemolysis. Those two things can combine. Another is Yeah, patient didn't have any risk factor for lepto. As I said, it was probably because I didn't have anything else to say. But looking back now, uh, if I could say, okay, no risk factor for leptospirosis can present like this, but no risk factor, and then what would explain uh, anemia plus mild thrombocytopenia? As I said, it's just two things from outside: the viral infection, the malaria, and the friend of malaria is a babesia. I think if I went like that, I would have found this thing. But yeah, a very good teaching point. Very good case. Thank you.
Well, you did a great job actually. I mean, just mentioning babesia, that speaks to your very wide knowledge base and familiarity with conditions, some of which may be not very endemic in our setting, but it's important because even medicine itself is global. So what's interesting is, I believe you've seen this, Joseph. I solved a case at one time, and I believe I shared this in the past. I solved a case. It was a CPC case in the New England Journal of Medicine, and it turned out to be malaria, which is very surprising. I mean, someone from our setting would have made that diagnosis very reflexively, but it was very delayed. So that is someone who is originally from the United States, and if I remember correctly, it was the Massachusetts area, who had traveled to Tanzania for a couple of weeks. And then he went back and presented with symptoms. And I think hemolysis was one of those symptoms. So, as you can tell, people, one of the things which is very helpful to consider the base rate, which is what are the common conditions in our settings. So, for them, it's very hard to think of malaria because malaria is almost non-existent in their setting, and once they see it, they are 100% sure that these are imported cases. But it turned out to be malaria after delayed diagnosis and patient moving from one facility to another, and then finally a diagnosis was made. So I think maybe we should not relax and say, okay, we do not have babesia in our setting, or we do not have Lyme in our setting. Uh, they could be imported cases because the, the 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 world is becoming like a village. Mobility is high, and therefore you can have imported cases. You think of all the possible differentials that are present in our setting, and they are not present. And these illnesses can be very severe. As you know, malaria kills people. So the same for other infections if they are not promptly diagnosed and treated. But I think the most important teaching is, as we always say, it's about the journey rather than the destination. So the way Joseph approached the case, I've been even thinking about malaria, babesia, and all other conditions that could explain malaria. I mean, that could explain the jaundice. So I think that was very commendable. So that's very inspiring to me. I'm not sure about others. That we need to keep reading and practicing, and this is one way to do it. The way you dissected through the labs, which were very messy, lots of crazy signals from all directions, but you were able to cut through the noise and just pick the signal which brought you close to the diagnosis, or at least narrowing to the most likely differentials. So thank you very much for teaching us. So it's we are past the hour, but if there is anyone with any burning comments, please welcome before we close the session. If there is anyone, you can just unmute and speak before we close. Yeah, I do not see any hands. It was good having you today. So we didn't send reminders. So whoever you see in this chat is someone who is very self-driven, who is very, very interested with the learning that is taking place. So congratulations and appreciations to everyone who joined. We hope to see you next weekend. Have a good night.